Extensor digitorum longus muscles in which compartment? What are our options? Start there. What are the names of the compartments? I didn't lie. Mostly. There is no deep lateral, there's just a lateral. So, deep posterior, superficial posterior, anterior, and lateral. Right? So, at this point, if you're, I don't remember what belongs in that list, then again, use your body. Right? Extensor digitorum longus. So, what piece of the body are we working with? The digitorums? What are those? Your toes. Your digits. Your toes. Right? Now, extensor, what is that? What action is that? Extend. Or is it so they go up or down? Up. So we're pulling toes up. Muscles can only pull, they can't push. So in order to pull it up, it has to be on the top. Right? So we're pulling our toes up. That muscle and the tendons have to be on top, which means that muscle is going to be in the front of the leg. So anterior, maybe you have a hard time ruling out lateral, maybe, but anterior. And you can actually feel. If you pull your toes up, put your hand on your lower leg and feel where that contraction is, and decide, is my hand on the anterior, the posterior, on the lateral side? So work through it. It's not all solely about memorization. Yes, if it's rote memorization, you've got the capacities to kick out answers. But for any of these, you should be able to whittle it down. Help yourself out. You cannot approach my tests and go, ah! Because it's just not going to work out. You got to have the wherewithal that when you get stumped, you try to break it down and figure out those pieces. Okay? So, anterior compartment. Contraction of the rectus femoris muscle creates motion in which plane? Rectus femoris is in which muscle group? Quadriceps. Quadriceps muscle do what? Extend. Be confident. It's all good. Extend. It also flexes the hip, but either way, it's still within which plane? Sagittal plane. So imagine that big sheet of glass and you're standing in contact with it, flexion, extension, sagittal plane. What is the insertion of the quadriceps muscle group? Tibial tuberosity. Where have you heard any of these other terms? Where is ischial tuberosity? What's significant about it? Origin of those three. What group is that? Hamstrings, right? Yeah. So what are those three muscles that are the hamstrings? Semimembranosus, semitendinosus, biceps femoris, long head. Okay? Let's see, pes anserine. Do you remember that term? Can you roughly feel where it's at? Likewise with Gerdy's tubercle. So if you find tibial tuberosity right here, pes anserine is the big flat piece of turf to the side of it. Gerdy's tubercle, opposite side, same place. It's the bump that sits right there. Unique component about Gerdy's is that the ALL, the anterolateral ligament, comes down towards that spot. Pes anserine, there's three muscles that insert there. We'll talk about those. What is the action of the semimembranosus muscle? Semimembranosus muscles, which group? Start there. Hamstrings. What do the hamstrings do? Flex the knee. What else do they do? Because they start at ischial tuberosities. They start above the hip. What do? They extend the hip. Flex the knee, extend the hip. So, what do you see up there that we need to pick? Knee flexion. So again, tie the muscle back to a group, and it tends to become a little easier. I know semimembranosus, I know semitendinosus. Those fall in the hamstring group. Okay, what do the hamstrings do? And if not, well, you know they are, put your hand there, do something that makes it contract, and when you feel it contract, be like, oh yeah, I got it. 6, which of the following are in the triceps surae group? Gastroc, soleus, plantaris. 7, which of the following actions does the gastroc have? So it originates on the femur, and it attaches to the Achilles below the ankle. So it does plantar flexion. And because it starts on the femur above the knee, it helps. It's a weak knee flexor as well. When we're on quizzes, it's kind of all or none with these questions. On your exams, there will be multiple selects, but they will be 1 point per selection. So if there's 2 options, that'll be 2 points for that quiz, so it's not all or nothing. So get used to them, but they don't hurt you the same. They're not geared the same way when I give you full exams, because I'll reward you per point. What muscle unlocks the screw-home mechanism of the knee? It's the popliteus. What creates the screw-home mechanism of the knee?
Medial condyle.
The medial condyle. What about it?
It's larger,
It's bigger.
so it creates a rotation.
Creates rotation on the tibia. Which of the following muscles belong to the quadriceps muscle group? Select all that apply. VMO and vastus lateralis. The other 2 would be
Medial and
rectus femoris, vastus intermedius. I guarantee you there will be a multiple select for the hamstring group and the quadriceps group on your exam. Easy question. Oh, and for those who haven't figured out as you study, there are old exams posted on Blackboard. This class, once upon a time, many years ago, was fully fill in the blank on every test.
Wow. That sucks.
I got nice. In my old age,
They're
I
still
became...
hard.
What's that?
They're still hard.
Yeah, actually the interesting thing was it didn't really change scores. To go to multiple choice where the answer is still in front of you, it didn't change scores. And so I felt validated that I didn't have to go back to the abuse I had before. But those old exams are up and posted so that you guys have access to look at them. Which ligament restricts anterior translation of the proximal tibia? We talked about that in reference to being the anterior cruciate ligament. It goes diagonally through the joint and prevents that tibia from shifting forward. MCL restricts a valgus force. LCL restricts a varus force from the inside out. So if I look at my knee and I bend it, like a valgus force, something pushing from the outside, my leg will actually kind of angulate and bend. If I go from the inside, like an inside force, your leg looks more like it's just bowing to where it's rounded. So L is angulated like a valgus. So valgus and angles, and then varus is rounded, so it's varus and rounded and bowing. So that's kind of how I try to hold on to it in my head. What are the contents of the lateral compartment of the lower leg? So the lateral compartment has 2 muscles in it. Fibularis brevis, fibularis longus. And so anterior tibialis and extensor hallucis longus, those 2 are going to be anterior. Deep posterior tibialis is deep posterior, and then plantaris and soleus are superficial posterior. Cool?
Yeah.
As cool as it could be. All right. Just
so hard.
because I can.
Hello, I'm Bob Ross, and I'd like to welcome you. First of all, let me take just a moment to thank you for allowing me back into your homes. If this is your first time with us, let me extend a personal
You know Bob Ross?
invitation to drive you to
Everyone
our
should know Bob
and
Ross.
pay along with us each week. Let's go up to the canvas here and let's get started.
This is a remix of his painting show that they turned into a song about happy little clouds. Feel better now, like you hear Bob Ross sing to you while painting. It's just what blows my mind is the people that think the time should do these things.
Yeah.
Like, who has that time?
Have you seen the one like this for slap top? It's they turned like a slap top infomercial video into like it's called slap top rap. You should definitely invest in that.
All right. That's pretty what? It's gotta make it uncomfortable, man. All right. Yeah, that can't be. No, that. I should do one of these things. Probably that one. What do you think? All right. So, how do that one go down? I want you to come back my way.
Yeah.
Yay! Tom, Dick, and Harry. Remember them?
Maybe.
So, Flex, what's Tom and who's Tom?
Oh my god.
Tibialis
Yeah,
Posterior.
posterior.
Dick, Flexor Digitorum Longus. Harry, Flexor Hallucis Longus. Okay, so one thing we've got, let me pass out some angles so that you guys can have things in front of you, just for the sake of having things in front of you. Have a bow. Short change. Oh, really? You good? Would you like to draw some bows? Check. All right. Now they have so many feet. Okay. Man, some unique pieces about tendons as they cross joints. There's a lot of different ways that we can kind of get these things messed up, bound up, twisted up. So there's two structures that I want you to know that exist in a lot of different locations. One is a synovial sheath. Synovial sheath, you've heard synovial joints, that's the synovial fluid that's inside the joint. The sheath is kind of the same thing. If you picture in your mind an electrical wire, to where you have the functioning part of the wire running through the middle, but there's an outside protective coat. That's what we have with a lot of our tendons. There's this sheathing, coating on the outside of it, and the tendon slides on the inside. So there's synovial fluid lubricating the inside, and it kind of moves in and out of that. Good thing to know is that, well, pretty much anywhere that you have a tendon crossing through that joint space, you're going to have one of those synovial sheaths in there. And you can end up getting issues called tenosynovitis. Teno, tendon, synovial, itis, inflammation, or osis, right? So, you guys haven't touched too much with pathology yet or modalities yet. So, inflammation is really just chemicals. I mean, it's effectively a cell that's broken apart and it's alerting its neighbors to the fact that it's been killed. So your body actually recycles the pieces of that cell to start your inflammatory process. Really pretty cool. I geek out on biochemistry sometimes. So, but that being said, it's damaged tissue that's releasing cells, it's attracting other cells, that's creating that swelling. And inside of these sheaths, there's not a lot of space. Kind of like we talked a little bit about compartment syndrome. There's just not space for that to go. And the only way to heal things is to get a blood supply in there that allows your body to do things with it, to actually remove the junk and then repair the broken. And if you keep, if you can't get blood in to flush out the junk, and you keep pounding on it to where it won't have a chance to heal, then you end up with some bad days. So it may be, when you're looking at tendinitis, you will find that you'll hear tendinosis much more frequently these days. But tendinosis, degradation of a tendon, but within inside those sheaths, it may not be the tendon so much as it is just an irritation within the sheathing. And we just need to get the swelling out of that space. There's a condition called Decker veins. And it's the tendon sheath for your thumb extensors. And that tendon sheath is all like runs right in through here. And it doesn't get blood supply very well at all. To where if you get an irritation, if you do too much with your hands, all for whatever, all of a sudden you are playing too much Nintendo for the course of a week or something. And then you're not getting inflammation in that space, then it's really hard to make it go away. They'll do injections in the site with steroids that might help some. A lot of times they'll actually end up in slicing open the entire sheath just to expose it to let it drain. So recognizing that they exist matters, because as we look over the top of the ankle and into this area through here, all of these spaces are going to be bound in these sheathings. And that needs to be in your mind as you consider injury evaluations. The next structure that we want to talk about retinaculums. So retinaculums are a tether. If I take my hand and I flex it like this, so I have a muscle originating up here that crosses my wrist and then up to my fingers. So it's pulling all of these structures into flexion. If there wasn't a retinaculum, if there wasn't something that pins that tendon to the bone in some place, then it would bowstring out. It would take the shortest possible route and not curve with the bend that it creates. So retinaculums, they hold, much like a watch is holding this here, it's banding across to where even if my tendon pulls, it's a leverage point that allows it to not bend up. So recognizing where those are is beneficial as well. Superior fibular, inferior fibular retinaculums, superior and inferior extensor retinaculums are all ones that we need to focus on, or at least pay attention within our own ankle. So if you take your foot, let's teach class barefoot. So if you take your foot, so this is your fibularis longus, fibularis brevis. And it's going to go hook around that lateral malleolus. Except that tendon on me, it pops way up over that bone. So that retinaculum is not pinning it back behind the bone like it does in many people. It actually allows it to sublux a little bit. So that could, in some people, become a problem. There's some people who, so that there's a superior and an inferior fibularis retinaculum, fibular retinaculum. And it's pinning these pair of the lateral compartment muscles down in behind that lateral malleolus. Then we have a superior and an inferior extensor retinaculum that are going to band across the top up through here. Superior and inferior. And so all of the muscles in the anterior compartment, and I would encourage you to feel these, but take your shoe off and palpate across your ankle. Because we've got 4 muscles that go in that anterior compartment. So feel those tendons, because they're pretty impressive. And all of them are banded down by these retinaculums. So what are our muscles? What muscles do we have in the anterior compartment? Tibialis anterior. Extensor. Digitorum longus. Nope. Not brevis. Extensor hallucis longus, right? So we're going to extend the little toes, we're going to extend the big toe. Tibialis anterior. And then there's the 4th one, which is actually the 3rd. That really everybody's going to forget about. Tertius. Fibularis tertius. Okay? Yeah, so I'm telling you. The 4th is the 3rd, and it really kind of acts like a turd, because everybody's going to forget it. So you can feel that if you pull your foot up, you can start palpating those tendons and feeling where they go. Once again, your body, if you start getting origin insertion questions, you can start figuring out where most of those landmarks are without too much stress. So tibialis anterior is going to come over in about the top of the midfoot. We'll talk about the medial longitudinal arch momentarily, but there's an arch in here and it helps pull that arch upward. And you can feel that tendon. Peroneus tarsus, the fibularis tarsus, is a little bit more difficult because it's such a small little guy and he kind of hides in there. But the next one over is your extensor hallucis longus. And then you get digitorum next to it to where it comes out. Oh, I lied. I was just kidding. Fibularis is over here. Tarsus is over there. I'm grabbing the wrong side of the foot. So tibialis anterior, extensor hallucis longus, extensor digitorum longus, and then fibularis tarsus is going to come down into the head of the fifth metatarsal. But all of those are banded by retinaculums. It is possible to damage those retinaculums. Resolving that is not so easy. I'll spare everybody. Put the shoe back on. Okay. Okay. Bones. You should have looked at bones when you started doing osteo, right? Feel kind of sort of comfortable with those? Again, your ankle mortise is made up. You've got the tibia, the plafond, which is that flat part under the tibia, joining in that fibular notch with the fibula, so it kind of makes a little seat like this. It just kind of cranks on top of the talus. So talus sits in through here. So that makes we have actually two joints that make up the ankle here. Underneath the subtalar, so this is the talocrural joint, C-R-U-R-A-L, talocrural joint. And then the subtalar joint is under the talus on top of the calcaneus. Calcaneus comes in here, and then we start looking at the tarsals. So the rest of your tarsals are going to be your cuneiforms, your navicular, and your cuboid. Your cuboid's the big guy all by itself on the lateral side. Straight across from it, bumping up with the talus, is going to be your navicular. Then you have your three cuneiforms, middle, intermediate, lateral, going across from there. So you can poke and prod those all over your... Slide forward to that, and we have... so, navicular, cuneiforms, cuboid, and then we have the metatarsals, which are effectively the same as the long bones in your hand here. So your hands and feet are very much kind of constructed the same way. And then a whole row from your metatarsals into your phalanges. So tarsals, metatarsals, phalanges, and these are the digits. That's the balls of your feet right across there. Proximal, middle, distal. Your big toe just has a proximal and a distal. So, other joints that we have to worry about. Each one of these is going to be interlaced with ligaments. Each of those bones is connected to the bone next to it somehow. That's a lot of stuff to remember that we're not doing in this class. There are a few that I want you to know that are more specific towards sportsmen. There's a whole profession around the hand. It's called occupational therapy. They teach you how to reuse your hands. Hand surgeons specialize in focusing and learning on all of those ligaments within the hand. Podiatrists, others do the same thing with the feet. I mean, people specialize in this because there's so much junk going on that you can't hold it on your head. So, I'll limit how much we do here. But crossing here from the tarsals to the metatarsals, it lines up to be this lovely little joint called the midfoot. And it becomes something that's significant because you can damage that joint in any of these locations where the metatarsals cross over the tarsals. And as such, I mean, it's the point at which when you're walking, you heel strike, and your foot goes down, and we'll talk gait later. But then as soon as that heel comes up, it's the break that comes across your foot. Yeah.
What's the cross, or is it over here?
Where's that?
Where do you have? Yeah.
Right across here. So metatarsals, the proximal metatarsals in with the tarsals.
Okay.
Okay? So it's your midfoot. So you put a lot of load on that when you walk. And you can also damage that, and the only way to kind of really resolve that is to splint it, which arch taping works well, or orthotics, to help prevent any bending so that can heal. So, yay bones. There's 3 arches that we're going to look at. The midfoot, the transverse arch is the one I was just talking about. That kind of cuts across. You can see how these joint lines kind of line up right across through here. So transverse arch across the side of the foot. And then we have a medial and a lateral longitudinal arch. When you look at somebody's foot and they stand up, and you can see that there's this nice... Here, toss me a foot, please. Awesome. When I look at it, you can see this is the medial longitudinal arch. It is very much an archway in your foot. There's a lateral as well. It's just not nearly as pronounced. So what is this for? Well, it's unique. It's got kind of a dual role here. The first is, if I put weight on it, it will give a little bit. So it's slightly supple, more so in some people than in others. So if I put load on it, it's going to expand to absorb some of that. If I'm running, depending upon how you run, if you're running, it's taking some of that load. But as soon as you progress to a heel-off stage, it becomes extremely rigid. And it becomes rigid so that we can propel, that we can transfer that force. As we're pushing down on the balls of our feet and into the first and second toe, it can transfer that force through the bones and help you move forward. So it has to play a dual role. There's something called the windlass, W-I-N-D-L-A-S-S, windlass mechanism. And so I'm going to actually ask you to take your shoe off so you can see this, because it's really kind of cool. If you take the big toe and you extend it, almost rip it off, I think. So, extend the big toe. You will actually see your arch on your foot get higher. Take off your shoes, look at it. So, arch is here, nice long arch. If you all of a sudden lift your big toe, you will see your arch get more defined. It goes from flat to pronounced. It's rolling the ball of this joint downwards, which is forcing the bones of that archway, first metatarsal and your medial cuneiform, into your navicular talus into calcaneus, into a more defined archway that you can then transfer a load to. So if you've got damage in here, then it's going to become much more painful. Plantar fasciitis, part of the way that it does this is that there's this plantar fascia that we'll get to. There's this fascial tissue in here that by rotating this, it puts tension on it. And if that's irritated or damaged, then that becomes exceptionally painful.
It's like with heels, right? When you wear high heels.
Yes.
How it's like.
Heels are just ridiculous. Accept your height. Stop trying to be taller. Okay. So, medial longitudinal arch, kind of a big deal. Medial cuneiform, you can see that archway right up and through here. The navicular functions as the keystone of that arch. Do you know that term? Keystone? So if you look at any arches in any kind of architecture, there's a central block at the top. So it's like pretty much 2 tower stacks that lean into each other and they fall into a keystone. It locks it in place, and it holds all the load of the rest of the arch. And that's what the navicular is. So where we have issues is in pronation, where if we go into pronation too long or we pronate too far, if this navicular is dropping too much, then that windlass mechanism can't work right. So that keystone is very important in terms of how we stabilize that medial longitudinal arch, because if it's not stabilized somehow, then we have issues, and it minimizes our ability to walk efficiently. It increases our likelihood of injury from different tendinoses and whatever else, shin splints, tendinosis leading to a shin splint, which is just a bad term for the stress response in the bone, to stress fractures, to thanks for showing up to basic training, we're sending you home now. Yes, ma'am?
So the mid-foot arch that you were talking about first is also the transverse arch?
Yes. So this is your midfoot arch. So this is like cross-cut pulling the metatarsals off, and you're just looking at those row of bones that create. Now the way we look at it a little bit though is it's an archway from medial to lateral, hence it being transverse. But when we talk about that midfoot joint, we actually look at it more from a superior view to where we're bending it. So this view is an archway this way. But if I'm talking about that joint when I damage it, it's where this is flexible in flexion extension. So it's that process of walking that will cause this pain, yet the transverse arch is really kind of that cross-cut archway that goes like that. So yes, it's the same joint, but they're kind of different motions, different structures. Same structure, but different. Same but different.
So we're looking, like, I'm not too sure there it says anterior view, so we're looking at it that way.
Yeah, so taking off these metatarsals and slewing this bone straight across. And so it's just creating an archway. But when we talk about it functioning like a midfoot sprain, it's typically because we're flexing and extending. Okay? Same but different. Clear as mud. Glad I know. Motions of the ankle. Inversion, eversion. So from 0 means we're talking about 0 degrees in neutral. It's a little different than we did flexion extension of the knee, because that knee went from full extension into flexion. This, from 0, you can do about 35 degrees of inversion, only about 15 degrees of eversion. Plantar dorsiflexion. Plantar flexion we can get down to about 50 degrees. So neutral isn't sitting perfectly at 90, neutral is relaxed. And so you're going from here down about 50 degrees to plantar flexion. And then from here up about 20 degrees to just above a 90-degree angle. Man, there's joints all over the place in here. There's just a lot going on. What do you mean?
The angles for
0 to 50 on plantar and 0 to 20 on dorsal. So again, each one of these bones butting up against the next one is another joint. There's a lot going on. More often than not, you're not discriminating from one to the next. Very rarely are we going to have, I mean, these are all gliding joints for the most part, so there's very rare that we're going to have an isolated injury, but you can get them on occasion. So, subtalar joint. Go back to poking at your own feet. Because it's a good moment. There's a landmark I want you to know called the sinus tarsi. So if you take your foot and evert it, pull it out. So find your calcaneus, your lateral malleolus, your fibula. If you come forward, as soon as you come off of that bone, you're going to kind of fall into a hole. And if you evert that foot, then that hole kind of stays, yet you can feel tendons up and around it. That's called your sinus tarsi. You're actually pushing directly into where that picture, that circle is. You're pushing directly into your subtalar joint that way. Now this is a landmark that I want you to hold on to, because when we start talking about the ligaments that stabilize your lateral ankle, this is where you start to find all of the others. So good thing to know how to find them. Oh, that's why it doesn't want to play. I done killed the battery. I think I learned. Kind of sort of alive. No, maybe it just doesn't want to play. Oh, it's trying to do something. well. Moving on. So subtalar joint, kind of window into that bottom space down there. Talar navicular joint, so talus and navicular. This is going to be the first pivot point of you loading your ankle in plantar in dorsiflexion and then stepping off to where you're going to transfer from here as you move forward in that rigidity into the navicular. And again, this is a lateral view, but that's the keystone of that medial longitudinal arch. So this set of joints and through is pretty significant. And as the keystone, it's taking a lot of stress, a lot of load. So it's very easy to get stress fractures within the navicular bone. Calcaneocuboid. We'll see damage to it and around the area. There's a ligament called the bifurcate that we'll talk about momentarily to help stabilize this region. So it's outside of the specific ankle. It is a foot joint. But as we do things to prevent injury, like taping and bracing, if I don't do the right things in helping you dynamically stabilize that, meaning I don't train your muscles to be able to respond to your movement, then it's very easy to start messing up this guy right here, or this area right here. And then tarsal, metatarsal, cuboid. Isn't that pretty? Good stuff. This is called elephantiasis. So it's a parasite that gets inside the lymphatic vessel, so it plugs it. So you can't reabsorb fluids the same way. So you get some venous drainage, but the lymphatic system is shut down, and so you get gross, excessive swelling in the extremities.
What's the difference in lymphedema?
So lymphedema is a degradation of the lymphatic vessels that it's some of the same. It's going to lead to a progressive increase in fluid, and then there's like a lot of lymphedema therapists that they'll do massage and stuff to help drain and fix. So it's swelling from the lymphatic vessels. This is specific because it's tied to a parasite that causes it. A little boogie. I don't want to do arteries right now. We're going to do the venous plantar pump. Are we? Yeah. Okay, so unique piece that we have. So we have arteries, and you can find them and feel them, and we'll get back into them. And there's one right, the posterior tibial artery runs right in behind. But there's a unique little aspect about your foot that when you load it and it stretches out your foot, when your balls of your feet separate from your calcaneus, it's actually putting a traction on those vessels as well. So if I take a hose, and Jamie's got one and I've got the other, and we pull, the cross-sectional diameter, provided it has some give possible, will shrink as it expands. And because of that, it's actually going to force fluid in it, through, up, whichever direction. Now within veins, we have, if you remember way back from the days of anatomy physiology, veins have one-way valves. So when I do stretch it, it can only go one way. So give me something that causes significant swelling in the distal extremity, like an ankle sprain, inversion ankle sprain. The process of walking does not stress the ligaments that stabilize inversion. So walking isn't going to make things worse. But walking is going to make things better, because if I'm constantly loading that arch, it's forcing fluid out of that space. So when you have somebody who goes and gets an ankle sprain and they go see an ER, and the ER doc puts an air cast on them and crutches, and they're not weight bearing until they see an orthopedic 2 weeks later, they're not doing them a service. It's much, much more beneficial if a person can tolerate walking, that you have them go through that process of heel strike, even if it's a shortened step, heel strike into toe off because of this. Because it's going to help remove a lot of that swelling as it keeps repeatedly stretching and relaxing the veins in the lower foot. Yes, ma'am.
When you said about the swelling
Part of it has to do with protecting the ligament. Sometimes when you have a damaged ligament and you don't unload it well enough, then you're distorting all of the receptors that tell your brain what it's feeling. So unless we do some neuromuscular re-education, unless we retrain it into a new normal, then we typically have longer term issues. In most joints, in your knee, your ankle, your shoulder, a lot of your big joints, there's actually a muscle that gets shut off in response to the injury. So if you don't work on resolving that, then the instability will forever cause issues with the stability of, and it's just not going to allow you to be as stable, which is not going to allow it to heal quite right. And then you can add in that about 15% of inversion ankle sprains actually damage the talus, the bone itself, or at least the cartilage that's in there. But we never ever do MRIs because it's just a common ankle sprain. So if you have an osteochondral defect, if you damage the cartilage that is the articular joint surface, it's just going to hurt. Unless you do something about that or unload it to where it can't heal, then we're going to have issues. So there's a whole lot of answers to why it could have been. But it's one reason why people look at ankle sprains and go, it's just no big deal, it's just an ankle sprain, except, yeah, there's a whole lot of right ways to do things that people tend to miss. All right, so longitudinal arch, same picture we had just a moment ago with our plantar bump, right? The stability of this arch is very important. As we start looking at pronation and damage to this area, what does it mean to stabilize and control? Do we have issues because our static support, our passive support, our ligaments have stretched out, have been torn or whatever? Or do we have a problem because functionally our muscles that are supposed to be supporting this archway aren't doing their job? So taking a moment to understand more lists of stuff is a good idea. So statically, we have 4 ligaments that we want to care about. Spring ligament, we'll start there. Short plantar, long plantar, and then plantar aponeurosis. The plantar aponeurosis is your plantar fascia, which is probably a more common term for most people. All right, so grab your foot, once you get done writing stuff down, find the medial malleolus, and if you go directly below it, you're going to find you'll find a little bit of a drop underneath it, and you'll come back up on a bump. Find that bump? Good. So that bump is on your calcaneus. It's called your sustentaculum tali. Woo, that's it. Say that one 3 times fast. Susten, S-U-S-T-E-N. Susten, T-A-C, tac, U-L-U-M. Ulum. It's pretty phonetic. Sustentaculum. Second word is tali, T-A-L-I. So sustentaculum tali is actually this landmark, this bump right here off the calcaneus that you're feeling. Directly in front of it, cruxing between the calcaneus and the navicular, is the spring ligament. I've seen it injured in a couple of people, mostly swimmers doing dry dock training. Yeah, doing barefoot jump training. It's not good. Whatever.
We're not good on land, it's okay.
I understand, yeah. Keep you in the water. Safer for everyone. So again, if I end up seeing an injury here, I want to do something like tape the arch to support it, which is something you'll learn in class at a later date, which helps. Arch supports, orthotics, those can unload it. Put them in hiking boots for a few days that have a steel plate in it, because then they can't flex, they can't bend that arch. It puts the load in the plate, which unloads it. So there's all kinds of ways to work around it. But the big deal is that you want to splint this to take the pressure off of that. Short plantar, it's way deep underneath. Long plantar, it's longer. I don't need the landmarks that it attaches to. You can't get to it anyways. So just know it's there. And then the plantar aponeurosis, the plantar fascia. It's going to go from the balls of the feet back to the calcanea tuberosity, back here to the calcaneus. So again, that windlass mechanism, as I crank up that hallucis, and it creates that increased archway, it puts a ton of pressure into that plantar fascia. Ton of pressure. So those are static, passive. They don't do anything except they're ropes. They hold it from being yanked apart. So if you yank it a little bit too much, too often, too hard, you may slowly stretch them out. Or if you cause a little bit of a trauma and they need to heal, they're going to try to split themselves, and then you just keep walking on it and keep stretching it out, and it's going to have this constant irritation, and all of a sudden you get a plantar fascia that's like this thick. Because it's constantly trying to repair itself and splint itself, and it keeps creating scar tissue, and then every morning what do? You wake up and put your foot back on the ground and tear it back apart. Plantar fasciitis, miserable for the first few steps in the morning, because you're busy tearing open a scab that you spent the last 8 hours putting together. Your body will let you know that it hates you for it. So, dynamic means that we have an active control, a contractile control, something that moves, which means that we're looking at muscles. Muscular control is stabilizing this. There's two main mechanisms that we're looking at. The first one is grabbing this top part in through here and pulling it up. So grabbing the top of the arch and pulling it like a strut, like just holding it upright. So when these muscles contract, they hold the arch up. The other grouping is actually working to grab and pull the arch ends in towards each other, again like the windlass, increasing that archway by pulling in the outside edges. So, tibialis anterior and posterior. Anterior comes over the top and goes into your first metatarsal. And your medial cuneiform, but it's going to kind of blend all over that spot. Your tibialis posterior comes in. So, that's Tom. Tom slides in from the back and inserts in the navicular. Now, it's still pulling directly up, even though it's coming in from the back side. So anterior and posterior both help pull that up. When we look at shin splints, frequently we're seeing that, and we talked about lever arms and how things move, and if we increase lever arms, we get more force, whatever. Okay, so these muscles really like kind of working at a certain distance. And if you get too close, then they get a little kind of weirded out and uncomfortable. And if you get too far away, then they're like, I can't quite keep doing this. I don't like being so far away from you. So anterior and posterior, if you have pronation issues, so if this archway drops too much, if that navicular drops too much, it puts an increased tension. It drops these down by a few millimeters. So for every step you take, a few millimeters means there's a lot more force that it's trying to produce. So shin splints are a response to foot mechanics. So for all the people taping shins, if you stabilize and support the arch, you're going to have a much, much better result. Okay? So first option was to actually grab the middle of the arch and pull it up. That's TA and TP. The next piece is grabbing the two ends of the arch and pulling it in together. And that's Flexor Hallucis Longus, Peroneus Longus, Fibularis Longus. You'll see it interchangeable in many, many places. And the intrinsics, which means that there's a whole bunch of small muscles in the feet, and we'll go over those at some point in the near future. And I'll just leave them lumped as intrinsics. So they're muscles that are originating in here and coming here and dynamically pulling these things together. So Flexor Hallucis Longus, that's Harry right here. Harry comes in, grabs the end of the toe here and pulls it back to help pretty much pin from here to here to create that bridging. And then Fibularis Longus comes in from the lateral side and actually grabs here and pulls it back. I actually need to go and take Fibularis Longus and add it back in that burst group. I don't really need you to differentiate between the two, so I'm not too stressful about that. But the function here is that it's, seeing as how it's inserting right about the same spot that Tibialis Anterior is, it's still having more of an anterior pull than it is grabbing the distal and pulling back. Regardless, it's muscles that are pulling to stabilize that archway. So a mechanism to support somebody who has pronation-based issues is definitely to work on the muscular control and strength. If you ever want to feel like, find muscles that you never knew you had, go do a sprint workout on the beach in the sand. And the bottoms of your feet will be sore like you've never known possible. And it's so weird. So cool. Problems with Americans that were born with shoes on their feet. So we never work on the strength inside. Yeah. Skipping some because we'll come back for the sake of, all right, foot. We'll come back to nerves and arteries. I keep saying it, but it's still up there. So, ankle ligaments. We'll back up just a hair. Ankle ligaments. There are 3 main ligaments on the lateral ankle. What's this hole called right here? It's a subtalar joint, but it has, that space has a specific name. Sinus tarsi. Okay? Tarsal bones. So sinus tarsi. Sinus is a hole or a cavity within the tarsal bones. Okay? Sinus tarsi that gives us access to the subtalar joint. So if you put your finger there and you find it, so lateral malleolus, drop down, find your hole. If you go superior, that band right there is an anterior talofibular ligament, ATFL, the most common sprain in the body, associated with the most common fracture in the body. Ripping that bone off, an avulsion fracture of the fibula, is the most common way to break a bone in the body. Inversion ankle sprain, so you just tuck it in and roll over it. Find your sinus tarsi and go directly posterior. And in almost vertical fibers, you're going to get the calcaneofibular, CF, ligament. So that's going to prevent pure inversion separate from plantar flexion. So if that makes sense. We have plantar and dorsiflexion. And then we can invert, evert, invert. You typically at an inversion sprain are doing plantar flexion with inversion. So that's your ATFL. If you do pure inversion, you can actually feel this get taut. So put your fingers where that calcaneofibular ligament is, and you go pure inversion, and you will feel those fibers stretch out and turn that band into a taut band. The last one is posterior talofibular. So if you find that lateral malleolus, so anterior is anterior talofibular, calcaneofibular is kind of straight down. Posterior, it runs sideways. Just if you find if you find the lateral malleolus, go behind it and you're poking sideways, that's kind of the direction of the PTFL. The posterior talofibular ligament. So when we start doing injuries and managing, like looking at injuries, somebody does an inversion ankle sprain, and they damage just ATFL, it's going to be a grade 1 sprain. If they stretch it far enough, they can include the calcaneofibular, so you've got 2 ligaments damaged, it's a grade 2 sprain. A grade 3 sprain, you will have to fully rupture the ATFL to then damage the CFL enough that you can get to the PTFL. It is perfectly possible to have a mechanism that isolates any one of those. If somehow you go on pure inversion, you sidestep off of something like a curb, you can hit CFL. If you're backpedaling like on a field that's got a lot of potholes and your heel goes in, you can isolate a PTFL. Terribly fun and exciting. All right. There's also, across the top, as much as there is the retinaculums that sit on the top, there's a anterior and posterior tibiofibular ligaments. So a reinforcement of the syndesmosis, a reinforcement of the interosseous membrane that holds the that holds the tibia with the fibula together. So there's a thickened ligament banding in here in the front and back, somewhat above the ankle joint, that helps stabilize the two bones staying together. So you've heard in high ankle sprain, that's what this is. To where somebody goes up into dorsiflexion with rotation, and you're kind of peeling the fibula off of the tibia, and you're damaging that anterior tibiofibular ligament. Nothing you can do but let it rest. You can make life more comfortable if you compress the two bones back together so they're not stressed, but it just takes time to heal. On the medial side, there's a lot in this picture. We summarize this by this triangular pattern right in here, calling it the deltoid. So the deltoid ligament is the medial banding that pretty much covers darn near everything on the medial side. It is very, very strong. It's very hard to damage.
What's a good way to remember, like, just, common sense, but like, a good way for a spring ligament, because you said there's a lot going on. Is there a good way to remember?
What, all of these pieces?
Yeah.
There's ligaments everywhere. I mean, if I'm doing evals and I want to know, I mean, this is the deltoid. If I put them into eversion, if I stress that eversion, that reproduces pain that they're complaining of, yeah, we'll just call it a deltoid. And we might refer it on to get it checked, imaged, whatever, to make sure nothing else is going on, but for the most part, you'll treat it the same. So we've got spring ligament coming in across. There's your sestentactinum tali, your spring ligament, just to put it in perspective. And then short planar, long planar, and then planar fascia will go straight across here. So there is, okay, from a posterior view, posterior tibiofibular that we talked about momentarily ago, and this right here is your PTFL. So again, it runs almost directly sideways. That's your calcaneofibular. That's your Achilles tendon that's been cut so we can see everything. From the front, what do I want? This. So, lateral side. Sinus tarsi, anterior talofibular, calcaneofibular, posterior talofibular. Hiding in this picture, right in through here, going from your calcaneus forward into your cuboid, and then calcaneus forward into your navicular. It's called a bifurcate, B-I-F-U-R-C-A-T-E, bifurcate. Bifurcate means it splits. A Y ligament is another way it's referenced. So if I have, and the reason I want you to just kind of hold on to that, it's this bridging between the rear foot and the midfoot. So if I damage this, or have somebody who repeatedly damages that, and I go and put them into an ankle tape, or I put them in a brace, that limits their motion, the ability to further damage it. But I don't take the time to train their brain on how to use their muscles to not fall over. Then they may still fall over, but the brace will do its job, it'll spare the ankle. But that force is going to go somewhere. It's either going to go up or down. If it goes up, it's hitting the knee. So as they're torquing and tweaking, then now the knee's pretty stable. There's a lot of strength in there, so it's not going to do too much. If it goes down, it's going to the midfoot. So you can avulse this ligament, or any of these in here, but this area, the bifurcate's pretty susceptible to damaging the midfoot or avulsing that off the bone, which is a fracture. So you can take a sprain that we can probably return within a week, and we rip a ligament off that's going to take us 3 to 6 months of non-weight bearing to get it to heal. So again, it's recognizing if you're doing one thing, it's putting something else at risk. So you've got to be active in trying to resolve and manage all of the person and not dynamically control rehabilitation. Okay? It's 1:15.